All right, as we're just about a minute to lift off here to the start of the webinar, I just want to make sure everybody's getting settled in. They're having a good experience with Adobe Connect. If you are having any issues hearing me or getting into Adobe, Dave Purdy is standing by. His email address is listed in the upper right-hand corner of the pod here within Adobe Connect. His email address is dpurdy, that's D like David, P like Peter, U, R like David, R, D like David, Y at drivemedical.com. He's standing by for troubleshooting. You can also certainly use the chat pod here within Adobe Connect to let us know if you're having any issues. Excellent. So I have 10 o'clock Mountain Standard Time, 12 o'clock Eastern Standard Time on my watch. So we're going to go ahead and get this thing kicked off. I want to thank all of you for joining today and getting involved in our pre-webinar poll. Go ahead and share those results with the crowd now so you can see what your peers selected as far as their reasons why now is a good time, why now is a great time to passionately pursue Group 2 support services. Looks like in the lead is prior authorization. We'll be discussing that today. It's back, and it seems like you've got a lot of fans of prior authorization on the call today. Looks like in a close second is the changes associated with CMS. And third place is COVID. So no shortage of reasons, and it looks to me that many of you were on our Group 2 Why Now webinar last month, and some of those reasons carried over here. So great to see all of the exciting reasons why now is a great time to passionately pursue Group 2s. We're certainly be talking about Group 2s today. So we thought we'd start off the poll or start off the webinar with this interactive poll. So we'll go ahead and get started. I want to welcome everyone to the Drive Cares Applications for Success. We're calling this one Demystifying Group 2 Support Surface Coverage Criteria. As far as what is to come, well, we have a ton of valuable information and insight planned for you today surrounding Group 2 coverage criteria, presented by Drive's experienced team of regional clinical vice presidents. As you're all getting settled in, we encourage you to invite anybody from your office or your location, of course, following the 6-foot rule, and make sure anybody who would benefit from this webinar is in front of their computers. As far as housekeeping, you may have noticed that your microphones are not turned on and that our presentation using Adobe Connect is being delivered over voice over IP, better known as VoIP, or simply audio and video through your internet connection. However, we will be looking to get our audience involved early and often, both with interactive polls like the one you just contributed to, and a chat pod which will be left open throughout the webinar for any questions and comments related to what we're covering today. Again, if you're having technical issues, I'll give one more announcement here. Dave Purdy, he's standing by for assistance. His email address is dpurdy@drivemedical.com. If you're having any issues using Adobe Connect, please feel free to email Dave or simply use the chat pod in Adobe Connect. Now that we've got the housekeeping out of the way, allow me to introduce myself. My name is Eddie Faber. I'm the National Sales Trainer here at Drive Devilbiss Healthcare, and I am the producer on today's webinar. Now, my everyday job at Drive is the National Sales Trainer, where I'm responsible for training pretty much the entire sales force at Drive. Now, I'm sure many of you would agree that you learn the most about yourself in those uncomfortable situations. I know I sure have. And that's kind of my favorite part about this training position at Drive, is putting my reps in those uncomfortable situations and watching how they grow, how they develop and learn. I encourage all of you today to put yourselves out there a bit and make a comment or ask a question during today's webinar that maybe you're a bit uncomfortable with. Now, we know how overwhelming these unfamiliar times are for everyone personally and professionally. We want you to know we're here to support you, whether it's a webinar, a phone call, a meeting, in any way that we can. We've been busy working from home, like many of you, and brainstorming ways that we can help our customers not just survive, but grow their businesses coming out of this quarantine. That's why we have organized this series of webinars, which is just chock full of insight, best practices, and resources. So, while we're on that topic, I'd like to shine some additional light on this Drive Cares program. Now, today's webinar is the latest in a Now, today's webinar is the latest in a series we launched today as part of the Drive Cares initiative called Hope Drives Us Forward. Now, the Drive Cares program is committed to putting the latest education, evidence, and concepts in all of your hands so you and your businesses can thrive today and into the future, helping all of you to do what you do so well, which is maximize outcomes for all patients. Now, today, we're going to be talking about Group 2 support surface coverage criteria during obviously what we all hope is the conclusion of this pandemic. I could not be prouder to introduce the two Drive Regional Clinical Vice Presidents that will be speaking on this topic today, both of whom I've had the pleasure of working with as a sales rep in my previous role and now on the training team. So allow me to introduce to you our two speakers today, Karen Lerner and Dan O'Malley. Now, Karen, she's no stranger to the industry. She has a robust history working as an RN while focusing on care and rehab. She's a member of the National Pressure Injury Advisory Panel Support Service Initiative and has over 30 years experience educating industry professionals and clinicians alike. Prior to coming to Drive, Karen was a vice president of clinical services at a Northeast-based DME. How about Dan? Dan has over 20 years of experience in home care and long-term care settings while specializing in support services for the prevention and treatment of those pressure injuries. Now, Dan is the man when it comes to teaching home care providers how to implement successful support service programs. Now, Dan and Karen are going to be looking to accomplish this objective over the next 45 minutes or so, and that's to prepare you to successfully build and or enhance your existing Group 2 support service business. How are we going to accomplish that objective? We're going to stick to this agenda. We're going to have Karen start off talking about initial qualifications for Group 2s. We're going to move on to the important health record requirement when it comes to Group 2s. Then move on to coverage, continued coverage criteria, and finish with some of the recent changes in prior authorization request, or better known as PAR. So with that, I'm going to hand it over to Karen Lerner. She's going to cover a quick disclaimer before we get into the content. Karen?
Thank you, Eddie, and welcome everyone. I know there were some chats saying that they couldn't hear Eddie. I hope you can hear me clearly. So look, Dan and I are not CMS employees or lawyers. We're not DME billing experts. So over the next 30 minutes or so, we're going to give you guidance and insights, and it's considered and it's well thought out, but it cannot be construed as legal advice. Thus, this disclaimer slide. But be confident in what Dan and I are going to share. We've been involved with DME and support surface coverage and issuance for over 50 years when you combine our experience. And as you can imagine, over these 5 decades, we have learned a thing or two. So we're going to provide general reimbursement information only. Before filing any claims, all providers on this call, please, verify your current requirements and policies with CMS and any other payers with whom you conduct business. Today, we're concentrating on traditional fee-for-service Medicare, national and local coverage determination requirements. Many other payers do follow these same guidelines, but some, including various state Medicaids, do not. Some of those other payers will give you more leeway with less clear-cut, hardened rules. And when the payer is not traditional Medicare, it often pays to ask for authorization for an outright purchase of the Group 2 support surface rather than make it a capped rental as traditional Medicare always requires. And for hospice providers and those of you who rent and sell to long-term care and skilled nursing facilities, or you market Group 2s for retail, please remember fee-for-service Medicare rules do not apply. You're going to hear us use the terms pressure ulcer and pressure injury interchangeably because although our National Pressure Injury Advisory Panel changed the nomenclature to pressure injuries in 2016, CMS, LCDs, and other regulatory bodies still refer to them as pressure ulcers. The other terms on this slide are also still around, and you will hear and see them used and written in health records. The highlighted words and terms are the current, correct, or most commonly used ones. All right, enough about disclaimers and vocabulary. Dan, let's get this webinar started.
Thank you, Karen. All right, so we want to make this interactive and we want to hear from you. So our first poll question today is, under traditional Medicare, how many different ways are there to qualify a patient for a Group 2 support service? So you have the answers 1, 2, 3, or 4. Please check what you think your best answer is. And while I give everyone a minute to check off their answer, I just wanted to reference a review done by one of the DME MACs that we referenced on our last webinar that showed over a 60% denial rate for Group 2 support services. And the number one reason for denial was, yes, you guessed it, the patient didn't qualify. So I am now going to broadcast the results. Wow, looks like a good mix of different answers, which tells me we definitely need to spend more time on this, which we will. And if you're still wondering, the correct answer is there are 3 separate ways to qualify a patient for a Group 2 support service under traditional Medicare guidelines. So thank you all for participating in the poll. We definitely appreciate you staying engaged. So now we're going to review the 3 separate ways to qualify. The first way a patient would qualify for a Group 2 support service is if they have multiple stage 2 pressure ulcers located on the trunk or pelvis, and the ulcers fail to improve over the last month. And the patient has also been on a comprehensive ulcer treatment program for at least a month, which has included the use of an appropriate Group 1 support surface, regular assessment, appropriate turning, positioning and wound care, moisture or incontinence management, and nutritional assessment and intervention. These are the 6 components of a comprehensive ulcer treatment program, and any patient on one, the documentation should be readily available. The second way a patient would qualify for a Group 2 support service is if they have a large or multiple stage 3, stage 4, or unstageable pressure ulcer located on the trunk or pelvis. Now, later we'll dig deeper in answering the question of what large is, but just know that if a patient has one of these ulcers, they would qualify. The third way a patient would qualify for a Group 2 support service is if the patient had a post-myocutaneous flap or skin graft surgery to close the wound on the trunk or pelvis, and the surgery happened within the last 60 days. And prior to discharge from the hospital, rehab, or nursing facility, the patient was on either a Group 2 or Group 3 support service, and the discharge happened within the past 30 days. So we just very quickly reviewed the 3 separate ways to initially qualify a patient for a Group 2 support service. But the real meat and potatoes, or the easiest and most straightforward way to qualify a patient for a Group 2 would be the second way we reviewed, which was to look for either a single or multiple large stage 3, large stage 4, or large unstageable wound on the trunk or pelvis. Now, this brings us to an interesting chat question that Karen has for you. Karen?
Yep, thanks, Dan. So when an Iridian DME MAC Group 2 support service educational program speaker was asked the same question, what is considered a large stage 3 or stage 4 or unstageable ulcer? I'm going to give you her answer. But first, I want to know what you consider a large stage 3 or 4 ulcer. And you can base it on experience or just give me your best guess. It's not a poll, just in your chat. Give me what you think. So I see an 8 centimeters by 8 centimeters. And You got to love CMS, right, for using vague and subjective terms like large in their national or local coverage determination. And multiple is just more than one. All right, so I see one other person chatting, and then I will give you the Noridian response. I'm going to wait 1 minute. He's typing. A few people. Okay. While they're typing, I'm gonna actually show you. So I asked, right, this same question was asked, and this is how it was answered, and I'm going to read the exact answer. Oh, it looks like Erin Dolan has a good answer there. So, but this is how Noridian responded. There is not a standard definition of large stage 3 or 4 ulcer. There are things that can be helpful in determining the size of the ulcer, and they include information such as the beneficiary's height, weight, measurements of the ulcer, and any undermining or tunneling. So for the record, the beneficiary's height and weight should have absolutely nothing to do with this. But notice they essentially refuse to answer. And I've personally asked this question on numerous DME MAC Q&As, and no one ever gives a firm answer. But let's look at another actual later discussed response to the same question, this time from medical review staff. So DME MAC medical review staff, when reviewing medical records, generally considers any wound of 8 square centimeters length by width or more as meeting the definition of large. When measuring wounds, it's always in centimeters, not inches, and clinicians are taught to give length, width, and depth when measuring a wound, but when pressed to give guidance on what defines a large wound, medical review staff typically want to see at least 8 square centimeters measured length and width. Fortunately, the medical review staff added to this initial answer, and I'm going to read their further response. Other wounds are considered individually. We take into account, for example, whether undermining and or tunneling are present, the anatomic location on the body, and the size of the patient. So to paraphrase and summarize, if the wound's length times width is 8 square centimeters or more, you're good to go. But if the pressure injury is smaller than that, the beneficiary may still qualify if there's undermining or tunneling. So I'm going to further explain undermining and tunneling just a bit. So firstly, tunneling. Tunneling is what it sounds like. The tunneling wounds have channels that extend from the wound into and through subcutaneous tissue or muscle. Now undermining. Purse your lips a little, like you're going to blow out a candle. And imagine the opening of your mouth, right, between your pursed lips is a pressure injury. If I measure that opening, maybe it's 2 centimeters by 2 centimeters, and that's certainly less than 8 square centimeters. But now run your tongue under your top lip and your bottom lip. That's what undermining in a wound is like. So I hope you can visualize how much bigger that wound would be if there's undermining than just the length by the width. That's why it's important to look for the words undermining and tunneling in the health record. And now we're going to dive a bit deeper into the health record. So, Dan, I'm a wound care nurse. I have a lot of experience with pressure injuries and charting, so this stuff is really clear and it's easy for me. You're not a clinician. Do you think you need to be a clinician to understand what's said in a health record regarding pressure injuries?
Absolutely not, Karen. You just have to know what you're looking for. And think of this, many of our providers, they don't have wound care clinicians on staff, but have great success with reading medical records for coverage determination.
Okay, very good point, Dan. So for those of you who have participated in our first Group 2 Support Surface webinar, I trust you remember, and I certainly hope you remember, why ICD-10 diagnosis codes make it easier to qualify a patient for a Group 2 support surface. We will provide an ICD-10 lookup tool for all of you listening to us now, and your drive reps can also give you this tool. Dan, can you please tell everyone what this tool is all about?
Sure, Karen. When the provider receives the prescription, the order, the health record, they can simply check this easy-to-use list to see if the patient has a qualifying diagnosis code for a Group 2 support service.
Thanks, Dan. Now I'm going to show you an actual medical or health record from a prescribing clinician. We've changed the name and the demographics to assure there's no HIPAA violation. And I'm going to stay on this slide for a while. And as I point out a few things in this health record, I'd like you to please think about if you'd issue a Group 2 support service for this patient. And think about your answer if the patient has traditional fee-for-service Medicare, and if you think differently if this patient had workman's compensation or other insurance. This is not going to be a poll question. I'd like you to please use the chat. The R by heal is for right. Notice tunneling is described using 12 o'clock. Clinicians are taught to use the clock system to ensure consistency in length versus width. We consider the wound as the face of the clock, with 12 o'clock pointing to the patient's head, that's length, and 6 o'clock pointing to the patient's feet, and that's width. VAC or VAC references a brand-specific negative pressure wound therapy. I'd assume we have at least a few providers who issue negative pressure wound therapy. If so, please remember, if the negative pressure wound therapy is being used on the pelvic or trunk pressure injury, a negative pressure wound therapy LCD requirement is the patient must be on a Group 2 or Group 3 support surface. So without that Group 2 or Group 3 support surface, the negative pressure wound therapy being used on the trunk or pelvic pressure injury, if audited, would be denied. Note, please, this patient has a full-size bed. And let's assume this patient does not want nor is willing to get the semi-HB or semi-electric hospital bed also ordered here. Does that impact your answer? SUP air mat is short for support air mattress. So imagine if you receive these notes and the patient has traditional fee-for-service Medicare. Are you issuing the Group 2 support service? Please chat yes or no. Going to wait just a bit. Erin Dolan, again, knows her stuff. We got a bunch of no's. Okay, so what about if the payer has workman's comp or other private insurance? Yes, no, maybe so. Let me hear some responses. Chat box, please. All right. Bunch of people are typing, so while you're typing, I'm going to give you my response. Okay, very good, Melissa. So, under traditional fee-for-service Medicare, I think everyone was right. The patient does not qualify for a Group 2 because only wounds on the trunk or pelvic count. Having a hospital bed or not has nothing to do with qualifying for a Group 2 support services. There are more available product choices when the beneficiary has a hospital bed, but not having one does not preclude denial, as there are full and queen size Group 2s available, as well as overlays designed to be used on marital or standard beds. Now, when I asked about workman's comp or other payer, most of you said yes or possible, and you're also all correct. So remember, just because the patient doesn't qualify for a Group 2 under Medicare doesn't mean that another payer would also deny you. And nor does it mean that this patient would not benefit, right, from a superior offloading of the comfort features of a Group 2 support service. And before he or she orders one from Amazon, I'd hope you'd explain the benefits and why his or her physician ordered one. Now I'm going to show you another patient record. SAC is short for sacrum, which is lower back. If you issue this patient a support air mattress, are you confident the patient qualifies under traditional Medicare? Another chat box question, please. Yes or no. I'll give people a minute. Possible, and somebody's saying no. Interesting. So this patient does qualify. Although the wound is only 2 centimeters by 2 centimeters, which is not 8, there is tunneling, which makes this pressure injury a large stage 4 pressure injury, and it does meet the initial coverage criteria. All right, one last health record example. This time, some prescriptions. Imagine you have received both a blue pad script and a medical record prescription. It sure looks like Jane Sampson would benefit from and qualify for a Group 2 support service. But let's remember an RX is not part of the medical record, so we need backup, including the wound measurements written elsewhere in the health record. And it can be nurses or PT or MD or PO or DO's notes that describe the wound. So I hope you now feel confident and at least more knowledgeable about initial qualifications and health record requirements for Group 2 support services. But there's still more to it. And Dan's going to take the next few minutes to discuss what's needed after you get initial qualifying documentation.
Thanks, Karen. So now, let's talk about the elephant in the room, which for many providers is continued use documentation. So again, we want to make this interactive, so please, we would like to know how you feel about obtaining continued use documentation for Group 2 support services. As we've heard from some customers, is this being the biggest challenge? If so, please feel free to yell out via the chat pod window now, or let us know if you've been able to obtain this documentation with limited challenges. Please let us know your thoughts in the chat pod window about obtaining continued use documentation for Group 2 support services. Difficult, easy, good, bad. Give everyone a second to see what their thoughts are. Depending on the doctor's office, that's a good one. We have heard that. Bad, unfortunately, we have heard that as well. Documentation is always difficult for our office. So I'm seeing a lot of, being difficult to obtain, and we have heard that. However, we have heard from some, as some of this Group 2 continued use documentation is the most notes they ever get. So it's definitely a mixed bag, very difficult to get. So we get that. Now, for those, thank you for participating in that. For those of you who view Group 2 continued use documentation as a major obstacle, we're now going to try to change your perspective just a little bit. Now, again, as I just mentioned, providers, like yourselves, cite obtaining Group 2 continued use documentation as one of the biggest challenges, but try to look at it as not a hassle, but an opportunity. Collecting continued use documentation can be an opportunity for you to build stronger relationships with your referrals and could help create new relationships. It could even help you maybe get your foot in the door with referrals that you normally wouldn't have access to. And it's important to note, obtaining continued use documentation will often come from another source than the prescribing physician. So what tools exist to help you collect this continued use documentation for Group 2s? We already discussed the ICD-10 lookup list. And remember, wounds are never backstaged, meaning once a stage 4, always a stage 4. Drive developed a Group 2 continued use flowchart, which shows exactly what information you will need to collect on a regular basis to show continued need. And these forms could be integrated with your billing software. Dear Clinician and Dear Physician letters can also be very helpful in notifying referrals on the documentation you will need to continue to provide the Group 2 support service to the patient. Copies of all of these tools are attached to this presentation, and we strongly encourage you to download all of the materials to use as resources. So the real meat and potatoes of Group 2 continued use documentation includes getting the information that is on the Drive continued use flowchart regularly. This information includes the dimensions of the wound, dressing information, the use of a Group 2 is medically necessary, along with the patient and caregiver have been educated on repositioning, how incontinence is being managed, along with how the patient is being nourished. This information is essential to show that the patient still qualifies for the Group 2 support service. I'm now going to hand it back to Karen, who's going to go over some additional Q&A examples from CMS and the DME Max.
Thanks, Dan. And I am going to reference a few things from the chat box here, and thank you all. So if you notice that Erin Dolan saying that she's had success faxing to wound care clinics. So remember, and it's very difficult for physicians, but wound healing clinics or wound care clinics and home health agency nurses who are seeing these patients, they typically will have very, very good records, exactly what you need, including these 6 things that's shown on the screen right now, because if they don't document it, they don't get paid. So it impacts them as well as you. So remember to reach out to the folks seeing the patient, not necessarily the physician who was the original prescriber.
That's a great point.
So this is, again, an actual question asked during DME Mac Q&A. A participant asked, if the progress notes for subsequent months indicate no change for the ulcers, is this enough information, or must there be proof that they actually assess the wound? And they added, does there need to be proof that they assess the wound, or is this enough information? So let's look at the response from the DME Mac. And the verbatim response was, a licensed clinical medical professional does need to assess and document the pressure ulcer at least monthly if it is a stage 2, or it is usually weekly for a stage 3 or 4 or unstageable. The moderator added, if the ulcer remain the same, then there must be documentation of the plan of care on what is being modified to promote healing, or something specific that indicates that the group 2 is needed for wound management. So if the health record indicates Mr. Drive Devilbiss stage 4 coccyx, which is only your tailbone, pressure injury measurements are the same, or if the wound is getting smaller, there should be notes that explain the stage 4 wound. Remember, as Dan reminded us, there's no backstaging in pressure injuries. So the notes explain the stage 4 wound is stable or epithelialized or is beginning to remodel. There should be further notes stating, without the group 2 support surface or the Drive Med-Air Plus or the low air loss mattress or whatever the clinician is calling it, the wound progression will deteriorate. All this can be done, by the way, via telehealth. So Erin asks, where does the LCD state the wound has to be assessed weekly for stage 3 or stage 4? So Erin, I can tell you're experienced in that. It does not state it anywhere, which is an important point, because I have spoken to some of the top fee-for-service group 2 support services billers in the country, and they routinely ask for monthly wound records, not weekly, and they assure me and reassure me that they pass every audit with monthly, not weekly notes. I am just giving you verbatim responses from Q&As here, but great question, great question. Another question, how would we know if the pressure ulcer has improved after starting a pressure-reducing support surface? Would we call the beneficiary and ask them if it has improved, or do we contact the physician? What if the beneficiary has not been in to see the doctor after starting the pressure-reducing support surface? And the response was, the supplier should maintain adequate communication on an ongoing basis with the clinician providing the wound care in order to accurately determine that the use of the KX modifier still reflects the clinical conditions which meet the criteria for coverage of the Group 2 support surface. If the beneficiary is on a Group 2 support surface, there should be a care plan established by the physician or home care nurse, which includes, but is not limited to, regular assessment by a nurse, physician, or other licensed healthcare practitioner, usually at least weekly for a beneficiary with a stage 3 or 4 and monthly for stage 2. So notice this is not a real answer. Much like large pressure ulcer requirement, ongoing communication, regular assessment are very vague, subjective, and nondescript terms. So in our experience, good qualifying initial documentation is good for the first 3 months. However, at month 4, If you're going to bill a month for and any additional months, regular assessment means written wound measurements, a documented comprehensive wound treatment plan, and conforming there's been monthly measurements for the past 3 months as well as month 4. When billing month 4 and beyond, ask for these records every month to meet confident and audit-worthy continued documentation requirements. And I'm going to repeat, notice that I say monthly notes are okay. You, the DME, cannot provide the wound measurements. The patient can't do it. A licensed clinical medical professional must document the wound measurements and chart the comprehensive wound treatment program is continuing, which includes the necessity for the Group 2 support surface. So I hope by now some of the cobwebs about initial qualifications and required continued health record documentation, hope those cobwebs are a little bit lifted, but there's still one more detail you need to know about, and that's prior authorization. And Dan's going to walk you through that now.
Thanks, Karen. And before I move on to prior authorization, I did see David had a comment about difficult and vague documentation. I think you drove that point home as well, so good that he picked up on that being vague. So the Group 2 prior authorization program went national back in October 2019, but was suspended during COVID. However, this program has been reinstated in August 2020 and is the new process providers must follow when billing Group 2 support services to Medicare. So this brings us to another chat pod question. So a simple yes or no. Are you happy that the Group 2 prior authorization program is back? Curious on what everybody thinks out there. As we've heard, kind of a mixed bag. Yes, yes, woo. I wasn't expecting to see 4 yeses in a row, Karen. Were you?
Truth is no.
I was expecting a mixed bag.
Yeah, yeah.
So for those who did say yes, we have heard that from many providers because in the past you would put it out and not know if you were going to get paid. At least prior authorization means you have a good claim to move forward. So at least initially you know the patient qualifies. And if somebody was not happy that prior authorization is back, unfortunately that is the new process we all must follow. So one other thing about, that's why we like it. So one other thing about Group 2 prior authorization is the criteria hasn't changed. Okay. However, the claims must be submitted ahead of delivery along with all applicable documentation. Group 2 prior authorization is a great opportunity to teach your referrals what is required. So general information that is required for a Group 2 prior authorization claim include the BENI information, supplier information, physician information, HCPCS code, and submission date. Additional documentation that is required include a detailed written order and documentation to support coverage of the Group 2 support service. This is all routine information that providers should be familiar with. Now, providers can submit Group 2 prior authorization claims to their DME Max via mail, fax, or electronically. The timeline or response time for initial submissions will be 5 business days. If the claim is denied, the provider can gather any missing documentation and resubmit and receive an answer within another 5 business days. There is an expedited submission where the provider can receive a response within 2 business days. However, this will be very rare. And some reasons for denial of a Group 2 prior authorization claim could be the order was missing some information, or the same similar provision where the beneficiary previously had the equipment already, or simply the documentation wasn't enough to qualify the patient for a Group 2 support service. So I'm now going to hand it back to Karen one last time to discuss a little further why you should be excited about billing Group 2 support services, along with some tools and resources that are available to you. Karen?
Thank you, Dan. Look, I agree with Dan that Group 2s are worth it, or the juice is worth the squeeze. When you look at the medical or health record requirements for hospital beds and manual wheelchairs, they're no less detailed or nuanced than those for Group 2 support services. Yet the money you earn from an EO260 or a K1 is peanuts compared to what you make with Group 2s. I don't know of any other capped rental like other than Group 2 support surfaces, where it's possible to get acquisition cost back in under 3 or 4 months. Plus, every patient that qualifies and benefits from a bed and a manual wheelchair are at risk for or have a pressure injury. And if they're not on a Group 1 support surface, they should be. And if you're issuing and billing Group 1 support surfaces, then you really should be in a Group 2 support surface as well. This is especially true if you've bid for support surfaces in the 2021 competitive bid program. In the 2021 program, Group 1 and Group 2 support surfaces are in the same bid category. So if you do one, you have to do both of them. And it's the Group 2s that are truly worthwhile pursuing from a profitability standpoint and as a marketing branding opportunity for you as well. Patients who need Group 2 support surfaces are sick folks, and they need a lot of DME. So when you learn to do Group 2 support surfaces right, you'll be trusted to handle a lot of DME need-intensive patients, and you'll get those referrals. Right now, there's a lot of attention in medical and nursing journals stressing the outdated model of confining people to bed during care is dangerous and shouldn't be tolerated. You know, caregivers and family members are tempted to leave patients in bed to help prevent or heal pressure injuries. But it's well established that patients need to get out of bed, often to a wheelchair, and even better to a reclining wheelchair, to maintain strength and avoid complications of being confined to bed. So that's sort of my long-winded way of saying, if you're doing beds and wheelchairs, there's no reason you shouldn't also be doing Group 2s, because they're all intertwined and they're entangled, and they lead to cross-selling opportunities. And by far, the most profitable of these three DME categories are the Group 2s. So please reach out to your local drive rep, who will give you a bunch of tools and resources, including the two examples here on the screen. A great cheat sheet is our flow chart, explaining Medicare initial qualifications and the 3 ways to qualify a patient. And to remind your customers, there's more to Group 2 support surfaces than standard powered, low air loss, alternating pressure mattresses, or E0277s. This flow chart also reminds your referrals that unstageable wounds are now covered. Teach that to your referrals. The reason I think this is a big deal is in the wound management world, we're leaving more wounds covered with SCAR. We're not debriding them all. So there's going to be more unstageable wounds out there. And before ICD-10s or prior to 2015, unstageable wounds did not count for Group 2 support surface coverage. I guarantee you case managers, prescribing clinicians, home health agencies, even some wound healing clinics still don't know this. So we have an easy to read continued documentation requirement form. That's what's shown here on the right. You can template this into your software program or fax it or hand it to your marketing sales rep to give to your home health agencies or others who see your patients who are on Group 2s. This will help you get what you need to confidently bill with those KX modifiers for months 4 and beyond. It can take 6-7 months, even longer, for a stage 4 pressure injury to begin the 3rd phase of wound healing. And with good health record notes, you can rent many Group 2 support surfaces for long periods of time and even cap them out. So these documents and others, they're available from your drive rep and they can be downloaded from this program. I'm going to comment on Josh Hawkins, who knows about the Group 2 support surface HCPCS code of E0373. Absolutely. It's not nearly as audited as E0277, and it helps you properly match the product to the patient. I wonder if any of you bill E0372. It's another Group 2 code that meets many patients' needs, particularly those who refuse to get hospital beds. Drive has your back. We have you covered. This map shows the location of our countrywide sales support team, and it includes not only your local territory business managers or reps. You have access to Drive's regional sales directors, regional VPs, and clinical vice presidents like Dan and me. We specialize in everything pressure and especially Group 2 support surfaces. All of us at Drive and all of our marketing resources are available for teaching and training and coaching not only you and your staff, but also your referrals. Our final slide is a quick recap. So our goal today was to spray Windex, so to speak, on your eyes or on the window through which you viewed Group 2 support surfaces. We shared best practices, example Q&As from actual DME MAC Group 2 support surface discussion forums. We examined initial qualifications, health record requirements, continued coverage criteria, and prior auth requests. Please know, if your vision to pursue Group 2 support surfaces is still not crystal clear, let us help you and your business thrive with Group 2 support surfaces today and tomorrow. So thank you very much for your attention and your participation. Eddie has a few housekeeping notes to review, and then we're done, and you can be off to the races getting and issuing Group 2 support surfaces.
Okay, thank you, Karen. It's Dave, actually. I'll do the close for the webinar since we had a little trouble hearing from Eddie with his microphone. So in closing, I want to first thank all of you for attending the webinar today and taking time out of your busy day. And in a moment, I will ask you to chat any remaining questions that you may have on Group 2 support services. So we'll wait here for a little bit while you formulate any questions you may have and put those in the chat pod. But while we're doing that, I just wanted to point your attention to this file download area that both Karen and Dan made reference to. A lot of the support and reference documents that they referred to are here. You can feel free to click on each one and hit the download button, and you'll have that on your desktop. I should also mention that we will get you a copy of the slides that was presented during the presentation. We'll send those as part of the follow-up email that we sent out shortly after the conclusion of the webinar here in a few minutes. And with that, let me just pull up here and ask, what questions do you have about anything we covered today for Dan and Karen on Group 2 support surface coverage criteria? So I'll just pause for a second to see if there are any questions. I think, Dan and Karen, we've answered most of the ones that have come up in the chat pod so far, correct?
I believe so.
Okay. So I don't see anybody typing, but I don't want to assume that they're not coming in. But since we're running a little long on time, certainly you can reach out to us or your Drive sales rep and ask questions. If they don't have the answer, certainly they can reach out to Dan and Karen to get you the answer. But lastly, just want to point out that when we close the webinar here in just a minute, you'll be taken to a brief survey to give us feedback on today's webinar. And we just want you to know we do read those. We value your feedback. It helps us make adjustments and bring as much value as we can to these webinars that we deliver. So with that, I want to thank you all again for attending, and on behalf of Dan, Karen, and Eddie and myself, we wish you great success with your Group 2 support business, and please have a great rest of your day.
Thank you.